going to go ahead and get started right now. I'm Joyal Mulheron with Evermore. I am the founder and executive director of Evermore, which is a nonprofit dedicated to advancing bereavement care for all. As some of you know, I'm particularly interested in the intersection of science and advocacy, and so that has been the lion's share of our work in the last couple of years. And our conversations, our in the know conversations, are coming to you monthly, and they'll be with various bereavement and grief experts over the next couple of months. So I'm really super excited to share with you today and introduce you to Toni Miles. Toni and I were just talking before the podcast or the webinar got started, and we go back a couple of years now. We'll talk about that in just a few minutes. But the format today, what we're going to do is we're going to talk for about 30 to 40-ish minutes. Toni and I will talk for about 30 and 40-ish minutes. We'll learn a little bit more about her story, her work, what brought her to bereavement, and then we're going to shift to audience questions. So get your questions ready. We're going to have you drop them in the chat as we go. But without further ado, I am so thrilled that our first expert that we're interviewing for our webinar series is Toni Miles. Toni is an incredibly distinguished professor and physician. Just noting that we don't have that often, at least in the field of bereavement, where you both have an MD and a PhD. And so just thrilled to introduce you to her and a little bit more context on her work. Pardon me, is that she's really been studying the population health effects on death in society and how that comes to fruition for the family, for the friends, for extended networks. And one reason why I'm so excited to introduce you to Toni is because pre-COVID, before anyone really was thinking about bereavement as much as they are today, she completed the first statewide survey using the CDC tool in the state of Georgia. And we're going to talk about that a little bit more today. We're also going to talk about a best practices bereavement care toolkit and guide that she's put together for nursing home and assisted living facilities. And so we'll spend a little bit more time on that. Beyond her incredibly impressive MD, PhD, she also has very significant academic credentials as a former professor at the University of Georgia and now emeritus at Georgia. She's also teaching at Morehouse, and she has taught a number of different courses related to healthcare ethics, population health, chronic disease, epidemiology, aging, and I'm sure many more. She's also served some time in Washington, D.C. On the Senate Finance Committee many years ago, so she also gets how Washington works and what we need to know and when we need to know it and how we need to know it. And even beyond that, she spent some time at the Washington Hospital Center, which is a very large hospital in the D.C. area, serving thousands and thousands of individuals with very significant health and mental challenges. And so with that, I am just really excited to introduce you to Dr. Miles, and thanks so much for being here today.
Thank you for inviting me.
Are you okay? Are you on mute? I just want to make, there you go. So
you can hear me now, right?
We can hear you now. So thanks for being here today, Dr. Miles. We're just really appreciative of your time. Before we get started and dive into the meat of what we're going to talk about today, could you share with us what brought you here? How did you come to bereavement and sort of land here? And what is your interest and emphasis, I suppose, in this particular issue?
Well, I'm an old lady. I've been around for a while. So, I mean, for all of us, it starts with personal experience, losing family members. I mean, I won't do a cost accounting, but one one that comes immediately to mind is my brother, who died in 2012. And the chaos it created when he passed. But I've been interested in bereavement. I didn't call it bereavement in those days. I actually started my training at the Washington Hospital Center in DC when AIDS hit the city. And there were every day young guys, I was young then, young guys who were dying of this ferocious diarrhea. And, we were all the same age and we were young and lean and, and it was terrible. I saw the chaos that it created for them, their loved ones. There were family members that were completely undone by all of this. And the healthcare, some of the people that I trained with were not very kind. That's the other part of bereavement, is how some people who are not comfortable with their own emotions act. So over the years, I've, continued to pursue this and got really into it in a real formal academic way in 2012. Should I tell my Diane Meyer story? Yeah,
absolutely.
Diane Meyer is in New York, and she's a big proponent of palliative care. And she was writing a book, and I said, I'll give you a chapter on the epidemiology, because that's the tool that I use the most. Only come to find out there's no data on who we count dead people, but we do not count the people who are left behind, the people around the bed. And it wasn't until my work and some others that Joyal and I will talk about, when we really started to understand a big part of the issues surrounding bereavement are the people who are left behind. So I've been at it ever since.
Yeah.
Now, I'm going to embarrass Joyal before you go on. I'm going to tell a Joyal story.
Oh, good.
Because she,
great, Toni.
Yeah, she and I, during the pandemic, we're all locked in our house in these little boxes. And she and I were connected, I think, by Judith Graham, freelancer for Kaiser Health News. So one afternoon, we were on the phone, and we realized that we were both just about bereavement and what it meant and policy. I mean, most people think in terms of single, your own person or someone next to you. But when you finally understand it's happening at a population level, that there are millions of people who are bereaved, it energizes you in a way that, so Joyal and I found out that we both have that same level of crazy energy. And so here I am today.
Yeah, no, I remember that. I actually even remember where I was standing and when we were having our conversation, because we were at the very beginning, I think, of, there was data starting, really good quantitative data beginning to emerge for a problem that, sometimes when I'm talking to folks, I make the analogy of, you walk into a room and then you turn off the light, but you turn on the black light. And then suddenly you see this whole new system and this whole new world full of different connections. And for so many of us, it's such a huge problem hiding in plain sight. And it's so early in I would say in the movement and in the phase to raising awareness and bringing policy support to this issue that, it was really quite a moment for us to be able to meet one another. And be on the same page. That was rare at the time for me.
Me too.
Yeah. So let's talk about BRFIS.
Okay.
So let's talk about BRFIS. So BRFIS is the Behavioral Risk Factor Surveillance Survey, and it's used by CDC. I'm happy to have you talk more about BRFIS and why you chose it. Just want to make sure for folks in the audience, BRFIS might not be something in their daily vocabulary.
Yeah, it's a mouthful. It sounds like a noise that a colicky infant might make. But it is the public health Bible for the United States. every state does one. And I'm sorry to get so weedy all at once, but this is, if you guys do nothing else, those of you who are out there listening to this, no matter where you are, when you're off this call or off your Facebook or off your cell phone, I want you to reach out to your state public health office, because that's where they come from. Every state does its own behavioral risk factor surveillance, and tell them to add the Georgia bereavement questions. We'll talk about what those questions are in a second, but that's the advocacy piece. Because like I said before, when Diane Meyer asked me to write that chapter, there was no data. There's nothing. We can't see bereavement because we don't count it. And because BRFIS, it counts everybody. They tell us why we don't, how well we're doing with seatbelt use or, physical activity. It is so important to know these public health issues. It's been around. Yes, somebody put the BRFIS coordinators. Yes, be nice when you go visit them.
So, Toni, before we go, just so folks know, so BRFIS is used to measure like seatbelt use, smoking, e-smoking, these kinds of measures. That's the tool that CDC uses for the adult population. And so every state has their own BRFIS coordinator. And so that second link that's in the chat is to the state BRFIS coordinators, and they are accessible. CDC publishes their contact information. They are accessible, and so those are the individuals. If you're interested in having CDC measure bereavement through BRFIS, those are some of the individuals at your local state level that would be that you would want to be in touch with.
Yeah.
Sorry,
Thank you for that. No, that's great. So the reason I went through BRFIS is that you can take that one item and link it to all those other things. We always talk anecdotally about how bereavement makes people sick or so-and-so died of a broken heart, but you don't have the data to make that connection. BRFIS allows us to make that connection. And so in 2019, or in the 2019 field survey that Georgia did, they fielded 2 questions. Have you experienced the death of a friend or family member in 2018, 2019? And how many people in that category? And with those 2 simple questions, we opened up a world of being able to see that people who are bereaved will sometimes drink too much, or they will not move. I mean, so we're just now starting to put out those reports. And BRFIS gives you that line of sight. The questions themselves are inexpensive, and the survey, I sound like I'm doing a commercial for BRFIS, don't I? But it's okay. That's it takes a lot to get BRFIS done. And I want Joyal to talk about the work that she's done to get not only BRFIS, get us seen by BRFIS with these bereavement questions, but talk about the recommendation and the appropriations.
Yeah, so as some of you know, we're really focused on sort of the advocacy piece of this, not just sort of getting the data, but then how do we implement the data? And so what we did after Toni started getting her data back from the 2019 field survey, and some of that data I found to be incredibly compelling. We went to Congress and suggested that they add a provision to the US budget. And let me just pause here for a second. Now, we chose the US budget, which is actually not an easy process to certainly be a part of, or an easy process to navigate, but we've been incredibly fortunate in the last few years. That is the only bill that Congress has to pass in any given year. So we knew that if we could get a provision attached to the US budget, it's better than an independent or standalone piece of legislation that then you have to get through committees and you have to get people voting on it, and you have to cut through the noise. And anyways, it's very hard to do in Washington. And so we chose the appropriations process, the US budget process, as the vector to attach these BRFIS questions onto for CDC. And so, so working with Toni and her data, and if I don't want to get in front of you, Toni, there were a couple of pieces of your data, at least the preliminary data that we saw at the time. And I think we have some testimony that we provided, that Evermore provided, using Toni's data to Congress as to why they should justifiably put BRFIS in the US budget, and strongly encourage CDC to be collecting this data. Do you mind, Toni, if I just share a little bit of the data points that I remember from the testimony?
Not at all. I do want to call attention. We're seeing good work in the chat. Somebody, okay. Susan Westoff is aware, and Jenna has opened up the chat so that people can put their questions in. So yeah, go for it.
Terrific. Thank you for doing that. So, so at the time, pre-COVID, the initial BRFIS data that you found, approximately 45% of BRFIS respondents living in Georgia had experienced a death in the previous 2 years. And this is really important because this is before COVID even started, and that if we were to extrapolate that data out to the entire state, that population that you studied, to the whole state, we're talking about 3.7 million Georgia residents experienced the death of someone that they cared very closely about. The other piece, I remember that there were 400,000 people who had experienced at least 2 or more deaths, and that there was a disproportionate burden on African American populations, with almost 60% reporting the death of a loved one. And I just remember seeing all of that data and feeling for the first time like, holy smokes, it is hiding in plain sight. It is right in front of us.
Yes. No, we were all kind of gobsmacked and went through those calculations several times to make sure we hadn't made a mistake. 45% of and we're talking about people 18 and over. Those are the adults and teens at the end of their teenage period. We still have nothing for youth and children, nothing. And that's why I keep, I know this is one of Joyal's passions. The youth form of BRFIS is also done by most of the states, and you can add those questions to that survey too, and get a sense of how many people are coming out of their adolescence with a loss, with a bereavement. And I'm going to make that point really put it in your brain, because one of the things we saw when we first started analyzing the data is that the prevalence of binge drinking is really high in that age group. People who are in their teens and early 20s, maybe 55% of them answered the BRFIS. They're not ashamed. Yeah, I binge drink. And that is basically defined by 4 drinks in a setting if you're a woman, or 5 if you're a guy. So we know it's binge drinking. And when we started to peel that back, a large proportion of those young adults had been recently bereaved. So binge drinking is one of the mechanisms for the injury associated with bereavement, and one of the ways that we can think about helping people who are newly bereaved, especially young ones.
Yeah, and I would say the Nordic study, the review that came out of all of Norway, demonstrating that bereaved parents specifically have a proclivity to alcohol use, and to such a degree that it kills them eventually, is what one of those reviews recently found. And so it aligns very well with what you were finding. The other piece that really struck me with the BRFIS data was that you're looking at people who were in their primary working years. And so it was 18 to 64. And I thought that was really important from a policy perspective because we know that the death of a loved one is not an eligible event for FMLA job protection. And so we've also been using your BRFIS data along with some other data sets to make the case to Congress. And we did make the case successfully last year for the White House to add paid bereavement leave to President Biden's domestic policy agenda. It ultimately did not end up in the final Build Back Better bill, but that was a significant leapfrog ahead, not just to get job protection into his Build Back Better plan, but also get paid job protection into that plan. And your data really helped us make the case.
Yeah, it is. Thank you for that. Because, you know, when you're a researcher, you just sort of sit in your corner and do the data thing and you never see the end of it. I want to, on this data point, before it goes too far, what I want people to think in terms of doing is advocacy. And sometimes you need to show the pushback I've always gotten, and I'm sure Joyal got this too. Oh, you know, nobody cares about this, or it's just an old people problem. So a week ago, I ran a Twitter ad about bereavement, and I have one slide that has the data on it from the Twitter world. So can we bring that up at this point?
Absolutely, yeah.
Because this is the kind of stuff you can use for advocacy. Yes, that one. This, so on the left of this slide, you can see the age ranges of people who responded on Twitter. And Twitter, yeah, is a young folks, some people think, platform. And yeah, 70% of the people on this platform were under the age of 50. So this little 30%, can you see you can't see my arrow, right? So if you go to the circle, the pie chart, see the 30% there? That's the ones over 50. All the rest of the folks that you see responding to this tweet, and that was almost 13,000 impressions, which I'm told in Twitter analysis is a big deal. This is an issue. The article was in response, the tweet was in response to an article on bereavement care needs work. And all of the people who responded to this New York Times piece were in the United States or in those age groups. Amazingly, I got no trolls, which, you know, is always a good thing. The other thing I want to point out to you is on the right side of that slide are the percent bereaved by age in our Georgia data. So you can, I can't tell you how much of the 20% from the tweet is under 18, but you can see what Joyal's talking about. The 55 to 25 group, if you're reading from top to bottom, are the ones who have lost someone in the 24 months before survey. So you can take that slide. I just want, and these slides can be made available to you, I suspect.
Absolutely, yeah.
Yeah, but those are two pieces. Whenever anyone tells you it is not, bereavement is not common, not a problem, you show them these data and go, there are lots of people who are concerned about this and are willing to talk about it and appreciate those opportunities. So you can take that down now so I can see you guys.
I think the other piece that I remember from the data, I mean, the bereavement is an exposure to death is a significant issue for everyone, because we all lose someone meaningful in our life at some point. And obviously there's some people who are even more at risk of losing, not just losing a loved one, but I'm also, when I'm talking to policymakers, I talk about the frontline responders. So whether it's a paramedic, a firefighter, a nursing home person, or even a therapist. You know, we have so many grief centers or individuals attending to people in their communities, that with all of those exposures, all of those stories and experiences that people are hearing, they too now are exposed to the ramifications, the downstream ramifications of bereavement. So as you said, you know, and we wrote about this week in our blog, that it's not, that bereavement isn't simply a mental health issue, because most people want to just put it in the mental health bucket and say, check, we've done what we need to do. And this is going back to your data from Purpose and the tools that you've created for caregiving. It's much bigger than that. It's not simply a health issue. So the alcohol consumption, for example, that can lead to premature death. And we see this in the data, that exposure to bereavement or death can lead, whether it's a family member or a frontline responder, will lead to other public emergencies.
Yes, yes. One of the things that Joyal has really put on my head, because I'm a gerontologist and have been operating in geriatrics forever, but we have lots and lots of young adults and children who are bereaved because they lost both their parents. I mean, one of the things, when I saw the shooting in Highland Park, Illinois, I've lived and worked in Chicago for years, and that just struck me. What is going to happen to that kid? Who's going to take care of that child? And what Joyal put me on to is the vast majority of these children do not get the Social Security benefits that are earmarked for that. And so without a formal, this is where we get back to policy and population numbers. Without a formal structure to connect bereaved people with the resources that could be afforded them, we've lost our compassion, I would say, for widows, orphans, caregivers. Here's where the caregivers connect to bereavement. Yeah. If you spend your life providing care for someone else in your family, as you know, many feel called to do, you have reduced your Social Security benefits because you're not in the workforce and you're not adding to that. So we shortchange people who are bereaved in lots and lots of ways, lots and lots of ways.
Absolutely. And I'm going to put my passion aside, because I could go into the public policy side and talk about the downfalls and the gaps. And I feel very strongly actually about children and sort of the state of play at the moment, because they are at a tremendous disservice from a public policy perspective. That being said, so is everyone else. But let's focus on caregiving for a few minutes. And I'd really love for you to talk about the best practices guide that you've put together, how you came to caregiving, and sort of what your views are of the caregiving population, because I think it's particularly unique.
Okay. Thank you for that. You have stepped right into my current work. So when I kept looking, this is more story than anything else. When I kept looking for ways to get in front of people who are bereaved, to count them, to hear their stories, to see what the needs and policy issues are at a population level, I became aware that CMS funds quality improvement work in long-term care. Any of you out there who work in a nursing home or work
Toni, can I put a pause on this? I'm shaking my head like, yes. So CMS is the Center for, Medicare and Medicaid Services. It is the largest health agency within a structure called HHS in the federal government, Health and Human Services, and they have a budget of over $1 trillion. And so they are the government entity that provides Medicare or Medicaid to the US population. Okay, go, I'm sorry.
Yes, no, that's good, that's good. So I, through my work in geriatrics, connected with several long-term care nursing homes in my area, found out about I'm going to type this, or I'll get somebody to type it. Here we go. It's called the Civil Monetary monetary, I can't spell, penalty program. Every state has one. And it provides dollars to your particular building so that you can improve the quality of care. And what attracted me most is that whatever you propose to do has to be wanted by the residents and their families. And when you're done with your work, the circle has to be complete. They have to be aware that a change has happened. And so out of that, we got funding to go around the state of Georgia interviewing people in nursing homes. We have 60 hours worth of conversation from everybody from the top administrators to the people who feed the residents. We talk to residents and their families and family councils, and we have videotape, and we took all of that conversation and all that film and created 2 best toolkits for best practices in bereavement care, driven by the advice of those people. So we have one that we do with staff, because as Joyal said, people who work in those environments before COVID were constantly, it was like a repetitive motion injury. They saw every day or more people who were dying, who were at the end of their lives. And to work in a nursing home, you have to be a special kind of person. So you cannot get used to it, which is what some people say. You don't want someone taking care of you or your mother or father who is used to it. But they needed a strategy. Some of them have strategies rather to protect themselves, to help themselves and stay in the moment. We also heard from residents. Nothing like the voice of the residents. One of the residents I talked to who was retired was a cardiothoracic surgeon. Boy, did he have a lot to say about the healthcare profession. So anyway, during the pandemic, originally we were supposed to go out into the nursing homes, sit with people, do multiple shifts, because nursing homes operate 24/7, 365. But March the 9th, 2020, we had to vacate and we weren't allowed back in. And still, it's tough getting into nursing homes. So we had to pivot, become web-based. And now, because of that pivot and having a tool at the right moment, we've done people across the country. We've done staff and residents in Texas and Minnesota and Michigan, Washington State and Oregon. I figure about 4,000 to 5,000 people now have been trained in their own self-care for bereavement in this very special environment and care for residents and families. That is one of the most gratifying projects I've ever been involved in, because people get it.
Yeah, no, I mean, it's amazing. 4,000 to 5,000, that's really remarkable. I mean, the other sort of added lens that I think about with the caregiving workforce, particularly in the nursing home or assisted living facilities, you often have a compounded layer of hardship because of the low economic thresholds that those individuals often sit within. And so they're not only exposed to bereavement, like, somewhat like secondhand smoke. There's never a good dosage of exposure. But then on top of that, they're not able to have sort of the economic flexibility that other constituents or other people in medicine, frankly, would have. How do you coach those individuals? What are some of the tools or the practices that you suggest to support their well-being as they're doing this work?
So the first thing I heard, and I'm going to say I heard from experienced people, is that you have to recognize that you have a limit, that you can't do everything for everybody. And sometimes you have to step away. And so what I heard lots of stories about were people forming bereavement teams. So if one person has a person that they're caring for who passes, the rest of the workers will rally around their other patients and offload. It is a sharing of tasks that really helps facilitate things. The other thing that I heard over and over again was planning diminishes the injury. I mean, one of the things we realized yesterday, we were talking about home caregivers as well as the ones who work in facilities, is older adults who are at that stage of life have the luxury of planning for it. I don't know how many of you out there have Southern mother-in-laws, but I did. And she, like a lot of women I know in this part of the country, plan. They buy the plot, they get the headrest, they get, they pay for the casket, they make documentation. Planning, I cannot emphasize enough that planning for an event is so helpful, because it doesn't make you less sad, but it helps you it gives you a structure to operate within. And sometimes that can be very helpful. The other thing, I have a whole list. I have actually an infographic that I'm going to send to Joyal that we created out of that work as a starting point. The number one thing not to say to someone who's bereaved. Anybody got a guess? Joyal, you got a guess?
I know what you're experiencing. I know how you feel.
Yes. We had any number of
people.
I
did not know that. You did not tell me that.
But that is, that's the one thing you don't want to hear, because even if you're in a similar, you think you're similar in every way, it's your brother, and they will tell you, if you ask them, I'm going to smack you if you tell me that. Or, so we heard things like, you'll get over it. No. One woman who had a particularly, she had a rough time, did not want to hear. Some people who are religious will say things like, well, God wanted them. Or they're in a better place. She's like, first of all, I'm not an expert on what God wants, but, and so, if you ask people honestly and you sort of wait for their response, they'll tell you. And that's so important. So sometimes you don't have to say anything.
Yeah. Well, I was just going to say, Susan was just bringing up in the chat, everything happens for a reason.
Oh my God, no, yes. Yes.
Yes.
Anything that makes it sound preordained. Yes. Now, so the other thing I learned, can I do one more?
Of course. Yeah.
Okay. So the other thing I learned from listening to all of these people was there are two emotions associated with bereavement. So, hey, Joyal, you want to guess? We have not had this conversation.
I don't want to guess anymore. I'd rather I could tell you what I would think, which would be anger and guilt. Those would be two that come to mind.
Yeah, well, and everybody focuses on sadness, but anger is primo. And everyone I talk to who's skilled at navigating those waters recognizes that anger is an issue. One of the residents shared with me that she was really angry with her husband when he died because he didn't fight hard enough. Now, she has come, she was several years down the road, and I know that that's not reasonable, but that's how I feel about it. Now, this woman went on to meet another man and marry, which was kind of cool. But that, so not dealing with, the point I want to make with this is, if you've got millions of people bereaved, and even a quarter of them are angry, you have a real setup for violence that you cannot predict. This is the other.
That's a brilliant point. Yeah.
So
I did want to ask you, I mean, when I was listening to you talk about the nursing home piece, and then when I think about nursing homes or assisted living facilities, there is a terrific exposure, continuous and chronic exposures for the staff, but there's also a sense of community and solidarity to some degree, which I think plays an enormous role, because as you said, the first guideline being know when you have to tap out, know when you have to turn it off. You cannot absorb anything else that day or even that week. What would you, and I don't want to push you beyond what you feel comfortable with, but we're in an era where we're all at home, or we've all been at home, and we have family members or loved ones experiencing other hardships. And so many of those Southern women or other family members are care providing in the home alone, not within sort of an extended professional work staff. Do you have maybe 2 or 3 bits of advice that you might give to folks who are in that situation, who are at home and having to do this day in and day out? And frankly, I'll just say this from my experience of having a terminally ill child, you don't know when the end is. And so every day is just so intense, and every day could be the last day. And so you put it all in, but the emotional and physical toll that it takes on the individual is profound. So what would you say to the folks at home who don't have these extended workforces and support?
Okay, so she doesn't know this, but I have prepared. That's why I have these other slides. I have a couple of slides, because the first thing people who are home engaged in caregiving have a tough time seeing, and that's very realistic on their part, is that they still feel like they're alone. Especially since COVID has shut us all into these little boxes. So I wanted to see, okay, so go down to the slide where the maps are. Let's go to the maps. Okay, so one of the things I've had to work really hard to get people to see is that bereavement is more common in places you don't expect. And so these are, okay, what you're looking at here is 2 maps of Georgia. We have an insane number of counties, like 156 or 59. And this happens to be the 2 time periods that we asked about in our survey. And the darker the color on the left, the more deaths you have in the county. Counties meaning everything to Georgia. And that's why I kind of organized it this way. And the 3 counties on the left in the circles, the big brown one is Fulton County. Everybody knows that because that's where Atlanta is. When people say Georgia, that's what they think of. But there's other places in the state. The little one next to it in sort of a darker yellow is Clark County, where I live. And at the bottom in South Georgia is a little place called Sumter, Sumter County. So you can see Sumter, for example, had a small number of deaths. They're in the 52 to 1,000 or 1,100 range, and they have a tiny population. So you would expect that they would have low number of deaths. But the question I wanted to get after, and this is where we go with caregivers, which county has the biggest hit of bereavement? And so now if you go to the next slide, do I advance them or does somebody else do that? Advance the slides, please.
Maybe it's stalled.
There we go.
Here we go.
Okay, so now these counties, same 3 counties, Sumter on the left, Clark on the right, Fulton in the middle. What I did was calculate, because I'm an epidemiologist and that's what we do, the percent of people who live in that county who died in that 2-year span. And you can see now that Sumter County, even though it's tiny, 2%, they had almost a 50% higher, or twice as many, that's the word I'm looking for, twice as many deaths proportionately than Fulton or Clark. Excuse me. And if you take that number of deaths and you create a ratio, and I hope you guys are following this. So basically you have at the top, the number of people who are alive in that county divided by the number of deaths. You can see the numbers. Sumter has a smaller ratio, 42 people for every 1 death. The county is small enough that half of those people probably know that person. And so bereavement is spread around more broadly in small counties. Fulton and Clark, 81 persons for each death. The likelihood that you're going to know someone who died goes down, even though the numbers of deaths are higher. I showed this to people who live in Sumter County, and they were amazed. Small areas, small populations, a death is more, people are more aware of it. And so if you think about where bereavement resources might be needed, it's in these places where you have small numbers of people connected to a single death. But these are not just family members, this is the entire community. And this is a global way of looking at it. And this is, many of those people were being cared for by someone at home before they died. So caregivers got to understand they're not alone. And now that the restrictions are lifting, my joke is there's no pandemic in Clark County. That's not true, but people act like it. But it is important that we think in terms of the people that we know who are caregiving and reach out to them with bereavement reduction strategies, helping them plan for things, helping them with resources they might need. Even if you could just sit on the porch with them. I mean, these sound really homey, but on the next level, it's training all of us to be aware of the potential for folks who are bereaved, because bereavement, you don't get over it. You can take that slide down now. It is something that you process, and you'll know that you have, maybe I would say, successfully processed it when you can think about the person that you lost and smile. True story. My brother was a maniac for making yourself look good. And he gave me tips. That's why I have such lovely skin. He gave me tips. And so every time I'm doing one of his things in the mirror, I think of him fondly. That's effective grief work.
That's wonderful and a great tip. And I would encourage anyone who has questions to go ahead and put them in the chat. We have Hilker, Laurel Hilker. I'm sorry, I failed phonics, so I'm the last person who should be reading names that I don't know, or reading names at graduation, which would, I think, be the worst thing in the whole world for me. I really like what she's put in the chat here, that when you are home alone, that there are people who can come and just listen. I mean, just what you were saying, like the listeners and walking in nature and building that sense of community. Even for those who don't have it, outreaching to the senior centers or other community centers, and to be a part of that. So would love to have folks, if there are any questions out there for Dr. Miles or anything that we haven't covered, would love for you to offer your questions now. And Toni, while we wait for that, one of the things I found myself thinking about as you were talking about caregiving specifically, and the anticipation of a death or an anticipation of significant limitation for some time period. One of the things that we've been focused on from a policy aspect is the unexpected deaths, because so many of them, whether it's a heart attack or stroke, or homicide, suicide, overdose, there's just all of these varying things that people are experiencing. What are your suggestions when it is a sudden death exposure? Do you have any suggestions for people on how to attend to themselves, or even how to attend to others when these sorts of things happen?
Wow, it is like being on the beach being hit by a wave you didn't see coming. That's how it feels, right? You get knocked over and you roll across the sand and maybe there's some rocks. So I will start by that qualifier, because I think, we all get hit that way. So I'm going to talk personal now because I don't have any data to support. I would love to find out, and I will if I keep walking this path of looking at bereavement and research. But when I was supporting my husband, his brother died many, many years ago of HIV, and we were stunned. He didn't tell anybody he was sick. Everyone got just sort of hit out of the blue, and so my role was as his support for him and his mom, and his brother had a child who, she didn't know he was sick. She was a teenager. And so your role as someone in that situation is to really be attentive to the people who are struck that way, because they're wandering in the desert and they have a giant hole in them. So one of the things I had to do to prepare myself for the day of taking care of other people, this was back in the days when I could run. Those days are long gone. But I went to the track in the neighborhood where my mother-in-law lived and ran around it, just to get myself focused. In the pre-COVID era, people would show up at the house, right, with food for the family. And I saw all the food that people put on the table, and I said, God, they're trying to kill us. It was all the comfort food, fried chicken and ham and green beans and macaroni and cheese with salt and fat. And so one of my jobs was to, thank people for the food, but make sure that people got some green vegetables in there somewhere. Whatever it took to make the physiology work well. That was my sort of thinking on that. Make the arrangements. You personally, if you're not emotionally involved, you're better positioned not to be. We got any funeral industry people on the line? I hope not. There's some good ones, but there's some that will take advantage of people who are in a very emotional state. So having someone who can be your designated driver while you're rocked, especially in the earliest stages, is so helpful. I will tell you, I planned my father-in-law's funeral. He was a surprise when we heard about him. And I arranged it so that, the wake, this is the tradition I come out of, was more like being at a jazz club. I had a piano playing in the background, light jazz, and people were sort of buzzing around. It helped me feel better. And, I heard a lot of positive from people. Yeah, we like this. What is this? So, it's all about comfort and calmness when it's sudden like that, because you're just all over the map. I mean, does that make sense to you?
It does completely. And I would say that usually what I say to folks is that it's almost like a volume switch, that the volume is so loud in the beginning, like you can't hear others, you can't hear yourself. And so that just that continuity and that presence, as you were saying, and that patience is really important. So I actually have one last fun question for you before we sign off. So if we were on a desert island, a group of us found ourselves on a desert island, and we have to wait for it, and we had to sort of make a go at it. I am curious as to what chore or activity you would find yourself leading on behalf of our group. And then my second question is, what record would you put on our record player that magically came with us?
Well, okay, so easy. Those are two easy. Thank you for those softball questions. I like to cook exotic food. I spent December 2019, before the world shut down, in India. It was great. I learned to use Indian spices. So let's say on this magical island, I had spices, and I could, forest in the, bring. So every day I would cook something fresh and tasty and wonderful, because that, food is life, and getting people together. In the background, I like jazz. I like, piano jazz. So, anybody who's playing piano and they're doing a good job would make me happy. So there you go.
I love that. Well, all right, so we're at the top of the hour. There was one question just submitted, but what we'll do is we'll follow up with you offline, and we'll facilitate a response for you. We just have to wrap this up. But I just want to thank everyone for being here today. Really appreciate it. You can join our newsletter if that's how you heard about us. And also, if you like keeping the conversations going, we have a couple more coming up over the next couple of months. Next month, we're talking to Emily Smith-Greenaway, who's done some really phenomenal bereavement epidemiological work internationally. And one of her statistics that I just always find stunning is, in some portions of Africa, 60% of African mothers are bereaved, or have lost a child. And she can tell you a lot about what people say internationally in response to that statistic. I won't get in her way. Donna Gaffney, who's responded to many natural disasters and man-made disasters here in the United States, both on behalf of children and families. And then Megan Devine, who is always lovely and has a terrific advice on grief support for yourself and for others. So thanks so much for being with us today. If you want to keep the conversations going, feel free to donate. We're in a matching phase right now, so that would be really wonderful on our behalf. And just appreciate all of you for joining us, and Dr. Miles for being with us today. Thank you.
Thank you.